Good afternoon, everyone. Thank you for sticking around in the last presentation of this afternoon, so I greatly appreciate you all for sticking around to listen. My name is Jennifer Ducie. I'm a third-year resident at Johns Hopkins, and I have the pleasure of presenting today a new model that we created at our institution. It's a new low-fidelity model for cesarean simulation in residency training. As we all know, cesarean delivery is one of the most commonly performed surgical procedures in the United States, with more than 1 million performed annually. And in fact, in 2007, 1.4 million neonates were born by cesarean delivery in the United States. And as this graph depicts, this rate has been steadily increasing over the past several decades. This is a graph from the CDC. In July, throughout the United States, many new interns will perform their very first C-section. Most of the time we send them into the operating room armed with a scalpel on July 1st, when on June 30th we were barely allowing them to cut suture. This doesn't seem fair to either them or the patients. Simulation can fix that. Simulation training has proven as a very successful training model in the military and also in airline industries. Surgical and obstetric and gynecology residency training programs have been following in these industries' footsteps in order to create our own structured simulation programs. There's been an emerging body of evidence since the turn of the century establishing validity of these simulation techniques. The operating room can harbor quite an intense and stressful environment. This is not an ideal environment where surgeons should begin to learn to operate. Simulation allows residents to acquire the initial training experience in a risk-free environment before proceeding to conventional experience in the labor and delivery room or in the operating room. Many studies, both in the surgical and gynecologic literature, have demonstrated improvement in skills when residents are allowed time in the surgical skills laboratory. And several studies, only a handful of which are listed here, published in the OBGYN literature, demonstrate an improvement, a significant improvement in skills following simulation drills for both obstetric and surgical emergencies. Other studies have also shown that simulation is far superior to traditional lecture alone. There's two listed here. In this day and age, with much talk about tight budgets and a struggling economy, low-fidelity models may be the most practical to incorporate into residency simulation training. Several studies have demonstrated the equal efficacy of both the low-fidelity and high-fidelity models. Thus, if using a low-fidelity model provides residents with a comparable clinical scenario, these models should be employed in simulation curriculum. In a study out of the University of Washington by Goff et al., they demonstrated the low-fidelity models were just as effective at a very reduced cost. The Johns Hopkins Gynecology and Obstetrics Residency Program developed a new low-fidelity cesarean section model. Our goals were twofold: to improve resident surgical skills and knowledge of the steps of cesarean delivery, as well as to improve the confidence of residents prior to entering the operating room. Cesarean simulation was performed during intern orientation sessions in July using this new low-fidelity model. The model consisted of a number of hardware and fabric store materials. It was very easy to make this model, and it was assembled very quickly. Additionally, the materials used to create the model were pretty inexpensive. These were the items that we used in this model. As you can see in the lower left-hand corner, a baby doll was placed inside of a uterus that had been created from a crate foam that we routinely use on arm bores in our operating rooms that you see in the second picture on the top from the left. Blue bonnets, also obtained from the operating room, were wrapped around the foam uterus to serve as peritoneum in the bladder so as to create a bladder flap. And that's what you can see in the second picture and on the bottom from the left. Next, the abdominal wall was created using several different materials to represent each layer. Skin was created using a thin plastic tablecloth, and in our model we used a pink plastic tablecloth. The subcutaneous tissue was made from insulation material. At our institution, the majority of our patients are rather obese, so you can adjust the subcutaneous, the insulation layer according to your patient demographic. Fascia and rectus muscles were created using two different types of thick, heavy-duty fabric. And finally, rigid plastic flower pots were crafted into a female pelvis and secured onto a wooden platform for support. All components were quickly and easily assembled prior to the simulation session. And all available interns participated in our first simulation session using instruments we routinely use in the operating room. Attendings and senior residents were paired up with interns so that there was a one-to-one teacher-to-intern ratio. Immediate feedback on performance was provided both during and after the exercise. And I have a quick video clip for you. And you'll notice it's sort of in fast-forward mode, so I apologize. So this was identifying the pubic symphysis. Right now she's just outlining where she'll make her skin incision for the fan and steel. Now obviously cutting through the skin and subcutaneous fat layer, identifying the fascia, which is white in this model. Now she's cutting through the midline with the scalpel, and she'll extend the incision bilaterally using the curved Mayo scissors. This model also allowed for us to, we secured the rectus muscles to the fascia with, I wanted to say suture, with string to make it more lifelike. This is entering the peritoneum. This was identifying the bladder reflection, and then subsequently she's developing the bladder flap. Now she's making the hysterotomy with the scalpel, and you'll see it extends very aggressively, bluntly, ruptures the amnion, and then goes in for the head. We were nice and made it a vertex presentation for her. And with the same model, we did also allow for her to practice repairing the different layers, but for sake of going over my time, I eliminated that from the video. Following completing the cesarean delivery simulation exercise, all residents, including the second, third, and fourth years, were asked to complete an online survey. The survey consisted of 8 questions, 7 were multiple choice, and 1 was open-ended. These are the questions that were on the survey that we queried about the year of residency, what steps of the cesarean delivery did they struggle most with as an intern, how were they initially taught how to do a cesarean delivery, had they ever received simulation training in the past, how many cesarean deliveries had they performed, and how many cesarean deliveries did they perform before feeling competent as the primary surgeon. 24 of 36 residents in our program responded to the survey, 33% of which were PGY1. 20 of 24, or 83%, responding residents reported that they had received no simulation prior to performing their first cesarean section. For the question before you entered the OR for your first cesarean delivery, how were you initially taught how to do the surgery? 67% of respondents reported that prior to entering the OR, they received training by lecture alone. 16.7% reported that they performed simulation on a makeshift or informal model. 0% had received formal simulation training, and 8.3% did not get any training at all. For those who had received simulation training prior to entering the operating room, 95% answered that it did help. 95% of responding residents indicated that simulation helped in several areas, including improving staff safety, patient safety, improving technical skills, and also efficiency. 6 of 7, or 86% of participating interns indicated the simulation session was the most useful component of the intern introductory training. In conclusion, this very simple model achieved our goal to teach the steps and proper technique of cesarean delivery. With work hour restrictions, caseload and experience has appreciably decreased. Simple simulation models such as this can be used to fill in the gaps in our training, and this was very easy to incorporate into our session in July. These same models can be used to gauge and assess resident performance as well, and thus we encourage cesarean simulation to be a part of formal simulation training in OBGYN residency programs. In the upcoming July, we hope to kind of expand this into a pre and post test and also a performance assessment with the incoming interns. I'd like to thank Dr. Altman, who was kind of the brains behind this model, and she was also the director of the film, and Jeremy Altman as well as Dr. Beanstalk, Dr. Burriser, Dr. Patterson, and Dr. Sadden. Any questions? Yes?
Do you know that this helps your interns be better surgeons?
I don't know that it actually helps them be better surgeons. I think that it does enlist some confidence when they're going to the operating room, so it gives them a better idea of what they should be doing when they are in the operating room with a real person. I don't know if that improves their skills per se, because I think the skills definitely improve over time with practice and performance of the procedure over and over. But I think that it does, I think it helps them develop a better skill set before going in and performing their first.
Well, if you're not certain, you can test it by
exactly.
half of your interns do it, half of them not, and then just doing the GME surgical checklist with their first 5 C-sections following their introduction and see who does better.
Oh yeah, maybe we'll do that in July instead of just having everyone do it.
Could you repeat the question?
He asked if we think that the model actually improved the surgical skills of interns doing it, and suggested a design to see if it actually does help by kind of randomizing some interns to doing the simulation before entering the operating room versus not. Yes?
Why do you think so few of the second years?
I don't know. I have no idea. Laziness? I don't know. They're very busy in the second year, so maybe that was it.
Maybe that's it. Do you think there was a recall bias by your years? You recall things differently as a 4th year than you do as a 1st year about your first C-section?
I think so, because I do vividly remember my first C-section, and I remember being terrified. But it is hard to assess, you know, what I would have done differently, or how I think simulation would have improved my skills or performance during that first C-section. So definitely there was likely extreme bias. Yes? Dr. Abbott?
Oh, thank you, Jen. This is a great model. I was assuming that you didn't say that they sew everything back up and close.
Yes, yes, we don't normally leave the patients fully open, so they do practice that.
And how long does it take? How long do you give them? Can you do the whole thing in an hour, or?
Yeah, we did it in probably 30 minutes or so. We definitely didn't take as great care or time as we would in the operating room, but there were some difficulties with the model, I guess weaknesses with the model. Trying to deliver the fetus through the hysterotomy, there was a lot of resistance of the plastic head against the foam model, and then also really trying to drive the sutures through the fabric and the foam. It did sort of limit and increase the time, but I think they got the right idea. Anything else? Thank you very much.